Good morning. Hi, this is Babak, Larian. I'm here to do a live question and answer session for parathyroid disease, hyperparathyroidism, and so on. Sorry I got off a few minutes late, trying to navigate this new world we live in. In any case, hope you guys are staying home and staying safe, and all your family members are all healthy and good. So I'm going to go ahead and start by answering the questions that have come in. Obviously, these are very strange times. I think those of you who are affected by hyperparathyroidism find yourself in a very precarious situation because you fit into some different categories. Those who've had surgery and have questions about how to address it and may not be able to access your doctor or find that the answers are not clear enough. Those who are in the stages of waiting for your surgery, right, which now is going to get delayed, and that obviously adds to the anxiety that exists already with this condition and everything that goes along with it, the uncertainty of it, and now you're waiting and you're going to need to wait longer. And those of you who are trying to figure out your diagnosis, which now again is delayed. So hopefully I can address a lot of these questions. But let me first start by those of you who already have a diagnosis, waiting for surgery, and are having a hard time with your condition, And I think under these circumstances, this is when trying to see if a medication, cinacalcet or Sensipar, is appropriate for you, or I think it's actually more than appropriate. I think this is the time to try it. If you are symptomatic and are having problems with it, where the symptoms are affecting your life in a meaningful way, right? Some people have symptoms, but they're minor and they're okay. Some people are very much affected. And if you fit into the category of being very much affected by it, I think this is the time to try Sensipar, because not only is it going to be able to potentially minimize your symptoms, it also can give you a view of where you stand, in the sense that is this medication something that can work for you? Because the coronavirus thing is going to pass at some point, but things will not be back in place anytime immediately after that, right? And it may take some time before you are able to have surgery, both because physician and hospitals may not be available in time, or you may financially be in a position where you need to work, and during this time, this medication can potentially minimize the impact of the hyperparathyroidism and give you an opportunity or time to be able to adjust and get to where you need to go. All right, so that may not be a bad idea. All right, so let's start with that. But let me start with the questions now. Good morning from Australia, Christine Lucas Charles. Good morning, Christine. I had 2 parathyroids removed 10 days ago, and my blood calcium levels are perfect. Great. Should I not take osteoporosis meds to resolve my osteoporosis? I had been on Prolia for 2.5 years, but stopped a year ago due to side effects. My levels were at hip negative 2.1 and at spine negative 1.7 using Prolia. So Prolia pulled you out of osteoporosis, and now you fit into osteopenia. That's good. Or potentially pulled you out of it. But at this point in time, you have osteopenia, not osteoporosis, right? Which is great. I'm due for a DEXA scan, but we'll wait till post-corona. Thank you for your consideration. Christine, I have some great news for you. Let me flip this around and show you. So, I quoted this study a lot because I think it's pretty brilliant. So in 1984, these guys did this brilliant study at Columbia University. Dr. Rubin was one of the authors in this study. So they had 116 patients, right? They came in and told the patients, you have a choice. You can choose to have surgery, and the patient got to choose, or you can choose to not have surgery. So pretty much half the patients chose surgery, 59, and 57 chose not to. The numbers for the patients who chose surgery was slightly higher. Calcium 10.8 versus 10.5, PTH 144 versus 116 on average, right? So these had slightly higher numbers. And the difference between 10.5 and 10.8 is not statistically significant, but the difference between 116 and 144 is. So meaning a lot of the symptoms have to do with your PTH level, right? Not only your calcium. So again, 59 of those patients chose to have surgery. 9 of them were considered to be symptomatic, meaning in this particular case, they have kidney stones, right? But also could mean if they had fragility fractures, means they got bone fractures with very low impact, and so on. So the group that chose not to have surgery, only 8 of them had kidney stones. So pretty much the same kind of profile, right? Of those patients, the 59 that chose to have surgery, 100% of them had obviously normalization. They had successful surgery. 100% of them had bone density improvement, right? Which means that all 159 patients that had surgery, their bone density improved. And that bone density improvement, 15 years after surgery, was still present. So at 15 years after surgery, they had a 10% increase in bone density as compared to before surgery. So when people have parathyroid surgery, their bone density improves, and that improvement continues even 15 years down the line to be 10% better than it was before surgery. So if you're starting with osteopenia, Christine, right, and you already had a successful parathyroid surgery, you are going to show improvements in your bone without exception. And the reason why that happens is that, let me flip you around again. And I'm sure you know this, but the reason that happens is that when hyperparathyroidism causes thinning of the bone, the reason it does that is that when you have hyperparathyroidism, I'm going to start this video again. When you have hyperparathyroidism, I'm going to go here. These purple cells called osteoclasts, they dissolve the bone, right? The bones have these 2 different cells, osteoblasts that make bone, osteoclasts that resorb bones, right? And our bones are constantly through the struggle of, it's not a struggle, this is just the way of reformation of the bones. Constantly, bones are being resorbed and bones are being made. So the architecture of your bone is constantly getting rejuvenated and renewed, right? And that's how you know, during growth, our bones get bigger and stronger. That's why when you put weights on your bones get stronger. The pressure that is placed on the bones is important in improving the functionality and the strength of the bone, right? So when there's extra PTH, the osteoclasts get activated and start resorbing the bone disproportionately, and the osteoblasts are not forming new bones, right? And so that functionality causes thinning of the bones, just like the video showed. The interesting thing about that is that normally in our lives, we have a daily elevation of PTH twice a day. You get an elevation, right? Which is why when you do your blood test, it's important for you to do it at the same time every morning at fasting, because it doesn't happen immediately first thing in the morning, right? It happens a little bit later during the morning time, after a certain level of activity, right? And so first thing in the morning fasting, if you do a blood test, you're not going to get a surge, and which would give you a false impression that you may have hyperparathyroidism if you don't, right? So blood tests at that point is important. Anyways, going back to Christine. So Christine, for sure your bone density is going to improve. I would suggest not doing the bone density study after Corona is over. I'd suggest actually doing it in 1 year. You already have bone density that is not osteoporosis. So I'm assuming that the Prolia brought you into osteopenia, which is an improvement. So if you wait a year without having hyperparathyroidism anymore, that's constantly bringing your bone density down, and with doing weight-bearing exercises, you know? You don't need to do heavy weightlifting, but put pressure on your bones, right? And by doing that, in a year, you're gonna see, am I going in the appropriate trajectory? Am I showing improvement in my bone? In which case, if you are, you don't need any medications, right? And I would highly suggest doing it that way so that you don't have to depend on medications to do what your body does best, which is it heals itself, right? Our amazing ability to heal. So that's the path I would suggest for you. Good luck. I'm glad you got your surgery. I'm glad you're now 2 weeks out and healthy and unaffected. It is a little bit of a hard time to be going to a hospital setting, to be doing surgeries. Healthcare settings are a little daunting at this point. So I'm glad you're doing well. I mean, that's why I do any of my surgeries nowadays in a surgery center setting rather than a hospital setting, in an outpatient surgery settings, because in an outpatient surgery setting, you have healthy patients as opposed to a hospital where you have, appropriately so, more ill patients. And so the chance of encounters is a little bit improved. The control of the environment, because it's a smaller environment, is improved. So you can have more control. You can pick and choose your staff more easily and more readily and control the flow of traffic into the facility better. So I think that works out under the current environment much better. I had to do a cancer surgery yesterday, which normally I would have done in a hospital, but now I was able to do it at a surgery center, and it went extremely well, and there were very few people. There was nobody in the waiting room. It was just fantastic to have that option to exercise during this time. In any case, moving on. Julia, I have had high calcium and high PTH, classic primary hyperparathyroidism, but during the ultrasound, he saw 2 thyroid nodules. Nothing on the parathyroids. How can you have so many classic signs and symptoms and a doctor keep putting it off? I'm so sick, but because I don't act or look that way, maybe. All right. I'd say 99% of the patients who come in to see me for hyperparathyroidism, when you look at them, they look perfectly normal. And the reason for that is that they don't have one organ system that's failing. You know, they don't have kidney failure where everything goes off. You know, they don't have lung failure where they can't breathe and they're struggling for their breath. They don't have heart failure where they just can't walk, you know. They have slowing down of every system in their body, right? And because as human beings, our most incredible, the 2 most incredible things that we have going for us, one is healing, which is mind-boggling, right? And the second thing we have going for us, which is incredible, is adaptability. On a chemical level, on a physiological level, on a social level, we are the most adaptable creatures, right? And we have our intellect helping us navigate our adaptation in any case. So because we're adapting to the changes that occur with hyperparathyroidism, we may not outwardly show it. You know, we may go to work a little harder to get the same task done, and then when we get home, we crash because you just had to do so much more work to get the same job done, you know? And you are not outwardly, because you want to function, you know? You're a human being, you want to function at your best. And so, no, it's rare to outwardly see signs of it. So, you know, I can't say that when a person walks into the office, I'll look at them and say they have hyperparathyroidism. That doesn't happen, right? Almost never. Rarely, I'd say. Maybe a younger person who's using a walker because they're having so much pain, I could surmise that that's what they have, but I that wouldn't be with certainty either. So there's no outward appearance of it. Very little, right? You have kidney stones and fractures, but even that is not an outward appearance. That's just what you experience and what's happened. So why do people ignore it? Because why do doctors ignore it? Because they don't understand it. They think, well, I did an ultrasound, your labs, your calcium and PTH is not probably tremendously high, right? You say you have classic primary hyperparathyroidism, but your numbers, I'm assuming, are not high, because if you had a calcium of 12 and a PTH of 300, any healthcare worker could tell you. A medical student would tell you you need surgery, right? But if your numbers are only subtly elevated and all you feel are things that you feel internally and it's not outwardly present, then they're not going to be outwardly present, meaning a bone density that shows osteoporosis or kidney stones, they may be easy to dismiss you. They may do an ultrasound, which is a good scan, but it doesn't show a parathyroid that the upper parathyroid is a little deeper. Upper parathyroids are deeper, lower parathyroids are more superficial. So if you have an upper parathyroid that's enlarged and a little bit tucked in behind your voice box, your Adam's apple, a little bit, the ultrasound may not show it, right? So just because you have a negative ultrasound doesn't mean anything. You just need to pursue it more, right? So I would suggest at this point doing a 4D parathyroid CT scan to try to see where that is. But you have nodules, and you know, obviously you need to figure out the importance of those nodules. By that I mean, do they look suspicious and need to get a biopsy, or do they look very benign and just should be followed by ultrasound? But you move on to say, the uric acid is causing my body to be acidic. It burns my hands and shoulders, arms, whole body. It's awful. Then bone pain. I have such skeletal issues. It's unreal. Wow, you need to take action, my dear. The body reacts by lowering my temps to combat the hot flashes, however, losing electrolytes, causing severe entire body Charlie horses, shocks, or energy balls under the skin. So painful. It's quite suffering. I won't talk to the gastric acid that destroys my gut. The osteoporosis, tarlocyst, dextroconcave scoliosis, and skin problems from the hot flashes leaching through every pore. It burns like I feel your pain, Jules. You gotta find a doctor that's gonna take you seriously. You know, unfortunately, that may be hard to do. You know, and part of the reason I do this is because I find that a lot of the internists don't realize the magnitude and the impact of this disease. A lot of the endocrinologists try to go by guidelines that, you know, I think modern medicine is flawed because we are now so dependent on scans and blood tests to come up with a diagnosis, as opposed to the olden days where we would look at the patient and come up with the thing. So looking at the whole picture. And I say this because when I go on these medical missions to Guatemala and Central America, we don't have any blood tests, we don't have scans, we don't have anything, right? The patient comes in, we feel, based on what we're feeling and what we see, we decide if this person needs surgery or not. You know, I'm not talking about parathyroids because those you need labs, but other things, like a lump in the neck, there just could be a thyroid tumor, salivary gland tumor, whatever, right? Or sinus issues, or tonsil issues, whatever. Any of those things, we talk to the person. We get a feel of what's going on and what an impact that has. Like, for example, when we go there and someone has a hernia, right? You'd think in the Western world, hernia is not a big deal. You cannot have surgery at some point. It's not something that needs to be done right away. That's because we have desk jobs. You can sit with a hernia and be totally fine. When you live in Guatemala, in a volcanic country where everybody lives on a mountainous range, and they have to, every day, in order to go get water, they have to climb down the mountain, get to the well, put the water bucket on their back and walk up the hill, or go work in the farms to get food, to make food, to eat the food. A hernia is magnificently important because it's the difference between being able to put food on the table or not. So everything is different. In any case, I digress. But looking at the person is important. So I just read, Jules, your history here, and it gives me anxiety and pain just to hear what you're experiencing. So you really need this to get this done, and you may have to find a surgeon. You may have to bypass the endocrinologist and the primary doctors and get to a surgeon that's gonna do the necessary tests to get things rolling for you. But that's what you need. And it's tough right now because you're in this circumstance, and you may be a candidate for using Sensipar for now until the corona thing subsides, okay? So I would talk to your doctor about that at this point. I hate this, it's crazy but true. I need help. If it's surgery, I'm all for it. What should my next step be with my endo? I mean, I think your next step with your endo should be to ask them to send you to a surgeon, or find a surgeon yourself. Either way, okay? But that's the next step, because you need them to find your parathyroid that's abnormal by doing the appropriate scans. You've already done the ultrasound, maybe do a 4D parathyroid CT scan, and then go from there, all right? Good luck, dear, really. Betty Dagan. These are my March 16th, 2020 labs. Calcium 10.0, parathyroid PTH 54. The only other previous labs taken March 11th, parathyroid PTH is 60. They didn't do calcium. September, vitamin D is 37. June of 2019, calcium 10.2. March of 2017, calcium 9. Okay. I was diagnosed with hypothyroid in January 2019 and take thyroid hormones. Sex hormones were tested June 2019, and I started taking bioidentical estrogen, progesterone, and testosterone. July 2019, DEXA scan shows osteoporosis with the worst score negative 2.6 in the spine. I'm 69, I have no aches or pains or fractures. What should be my next step after the pandemic passes? What can I do now? Good questions, Betty. First, your vitamin D is 37. Well, it was in March of 2019. And getting vitamin D supplements is a good idea because not only it improves your vitamin D status, which is really good for the immune system and during a time of a pandemic or any other time, otherwise it would be good. So getting your vitamin D higher would be important. I'm not sure based on this one set of labs, by that I mean calcium and PTH done one time together, if you have hyperparathyroidism or not. Your calcium being on the upper side of normal at 10, PTH being on the upper side of normal at 54. But that's a one-time number. And I need multiple numbers of calcium, PTH, and vitamin D done at the same time to be able to tell if your numbers are off or not. Meaning the relationship between calcium and PTH is inverse like this, or are they both on the upper side of normal and they're hovering there, as opposed to having this relationship, which is a normal relationship that all non-hyperparathyroid patients go through on a regular basis, right? So my suggestion to you is get vitamin D and K2, which are complementary vitamins together. Take that as the supplements for now. Do weight-bearing exercises at home, not too much weight, to improve the density of your bones. Activity helps. Once the pandemic is over, I would suggest you do the labs I suggested, calcium, PTH, and vitamin D 3 times, all done fasting, first thing in the morning, right? Pretty much at the same time. And it just have to be 1 week apart for these labs to show the relationships, right? And if you see that the relationship is doing this thing, then hallelujah, you don't have hyperparathyroidism and you're good. You just need to take care of yourself, do weight-bearing exercises as a whole, and you'll be okay, all right? Good luck. Eva Shadler. Hello, Dr. Larian. Greetings from Copenhagen, Denmark. Hello, Eva. Pleasure to talk to you. Thank you for sending your questions. My next appointment at the hospital has just been canceled due to COVID-19, but my lab results came back yesterday. It all started November 2019 when I turned 50. Oof, I'm about to turn 50, so I feel it. With high blood pressure, fatigue, muscle weakness, bone pain, headaches, brain fog, and frequent urination. Eva, I have to tell you, I have all those things too, but I have 3 kids. 3 young kids, so it could be that as well. In any case, I don't mean to be facetious. Blood tests showed elevated PTH and an alkaline phosphatase, all right? Elevated calcium only once, the rest within normal range. Vitamin D low. DEXA scan confirmed osteopenia. I've been taking calcium and vitamin D supplements once daily since my last appointment 3 months ago due to low vitamin D levels, okay? And to confirm, rule out due to vitamin D deficiency. My vitamin D status is now within normal range, but my PTH is 9.1, so it's elevated, equivalent of 85.8 picogram per milliliter, and alkaline phosphatase is still elevated at 132, which means that there's bone turnover. Alkaline phosphatase is reflective of bones having problems, right? It could also be a liver issue, but then the other liver tests would also be elevated if that was the problem. My calcium back in the normal range at 2.36 millimoles per liter, which is equal to 9.44 milligrams per deciliter. Calcium have only been elevated once, back in December. The oldest calcium value I have is 9.28 in 2013. My kidney and liver values are all normal except alkaline phosphatase, magnesium, phosphorus are normal, albumin borderline low. My blood pressure is well treated now with angiotensin II receptor antagonists. I still have fatigue, muscle weakness, pain, and bone pain. And frequent urination, headaches, and brain fog are better now, but comes back once in a while. I have normal thyroid function, isthmus, but got half of a gland and isthmus removed 7 years ago due to multinodular goiter, which was benign. I was diagnosed with acid reflux in 2015, where I also had a period of elevated alkaline phosphatase for a period, fatigue, muscle weakness, pain, similar to what I have today. Calcium PTH were not measured. My mom had severe muscle weakness and pain in her legs, and she had trouble climbing stairs at the end. She also had high blood pressure and osteoporosis. My grandmother as well, but she never got diagnosed. Now to my question, do you think I have parathyroid problems or could it be something else? High calcium intake needed? Love your talk, by the way. My pleasure. Lab results converted from Scandinavian to US units inserted. Oh, thank you very much, Eva. All right, so you managed to improve your secondary hyperparathyroidism would be due to low vitamin D or kidney failure, which you don't have, but you had low vitamin D. So when you have low vitamin D is a suppressant of the parathyroid system. Let me show you. So let's actually go back. All right, so when calcium attaches this is a parathyroid cell. So on the surface is the calcium receptor. When the calcium attaches, it starts a process, and that process releases calcium inside the cell, which stops parathyroid from being released. When calcium is not attached to the calcium sensing receptor, that inhibition goes away and the cell not only produces PTH, it also releases PTH, right? Now, on the promoter site for production of PTH in the nucleus, there's the promoter site that calcium attaches to. There's also vitamin D. Vitamin D stops production of PTH, right? So when you have vitamin D goes and stops PTH production. Vitamin D also goes and affects this protein called P21, and P21 slows down cell duplication and growth of the parathyroid gland. So when you don't have vitamin D, right, you don't have production of P21, the cell starts duplicating and getting bigger. So you get secondary hyperparathyroidism. You also don't have inhibition of PTH, so you produce more PTH, right? So when you don't have vitamin D in your system, your parathyroid glands produce more PTH and they also grow, okay? And so you had that before. Your vitamin D was low, your PTH was elevated, which could cause your calcium to come up a little bit, right? As compared to the numbers you had a few years ago, right? But now you replaced your vitamin D, okay? And by replacing your vitamin D, you normalized your vitamin D levels, but your PTH is not normal. And so if your PTH is not normal still, despite improvement in your vitamin D, and your calcium is now on the upper side of normal, right? And your PTH is elevated, vitamin D is exactly normal, you have normal calcemic hyperparathyroidism. And if you have normal calcemic hyperparathyroidism with high blood pressure, with bone pain, issues that you're having, then you need to address it, right? So what I would suggest at this point is to do an ultrasound and potentially a 4D parathyroid CT scan to see. If you identify a singular enlarged parathyroid gland, then that's an easy decision to make, because then you have a singular parathyroid adenoma, but most likely, and you can have a very simple, easy parathyroid surgery to address this issue, okay? In the hands of an expert. And that's, okay? So I think that's the path I would suggest taking you. But I think you're very intelligent, clearly based on how you presented this thing. and the maps and the tables that you made and so on. And so I think you understand what's going on with you, and you've done the work for the doctors. You've clearly presented that, this was my calcium number, now it's higher, my PTH is elevated despite taking vitamin D and correcting my vitamin D deficiency. I continue to have symptoms. I'm only 50 years old. I'm very young. I gotta say that, right? I'm very young, and I don't want to be dependent on medications, blood pressure medications, or anything else, or lose my bone density in the future. I want to have treatment, right? A definitive treatment that potentially can reverse or stop these processes. So that's my advice. That's what I would do. Maybe I should go check my PTH and calcium levels at this point, since I'm having similar symptoms to you. In any case, but that's what I would do, all right? And anyways, moving on. Good luck, Eva. But again, you're also not in a rush. You can wait for the pandemic to be over to take action, because this is a slow moving process, at least at the numbers that you have and the symptoms that you have. So you can. And you probably won't need Sensipar as a trial because your symptoms are not that dramatic, okay? So you can wait to address this. Moving on. Ariella Guska. Hopefully I said your name at least without insulting you. My question: patient has high PTH 76, high calcium between 10.5 and 11.1. Patient has a large nodule about 3.5 centimeters that occupies almost all of the right thyroid. Biopsy says non-malignant. That shows active during a nuclear medicine test. No parathyroid detected with a nuclear medicine. Could it be the thyroid nodule causing the high PTH and high calcium? Only if that thyroid nodule is actually a parathyroid adenoma. But at 3.5 centimeters, I would think that the PTH production would be significantly higher than 76 for an parathyroid. So no. So what I would gather based on what you're saying is that incidentally, this person also has a large thyroid nodule, right? There could be a parathyroid adenoma behind it, which is why this nuclear scan is giving you some off information. There are times when a thyroid nodule itself can show hyperactivity on a thyroid scan. There are times that there's a small parathyroid adenoma right behind it, immediately adjacent to it, that's showing the activity, and the scan is not clear in showing the difference, right? I would suggest doing an ultrasound, and if not fruitful, again, a 4D parathyroid CT scan to find it, because this person has hyperparathyroidism. And, if they find it and proceed with surgery, at the same time that large thyroid nodule can be addressed, because as you know, the guidelines from the American Thyroid Association for removing a thyroid nodule is any thyroid nodule that's more than 4 centimeters. If this is 3.5 centimeters, it probably will get there within a couple of years, so you can address both issues at the same time, okay? So I don't think the nodule is causing the elevated PTH. The thyroid nodules never really do that, unless they themselves are a parathyroid that is inside the thyroid, which can happen rarely, very rarely, all right? Good luck, Ariella. Marilee Rick. Hello again, Dr. Larian. Hello, Marilee. Thank you for the invaluable information and work. My pleasure. This time I have a more specific question. Have you by any chance ever come across literature that links hyperparathyroidism with OCD, or maybe treated a patient with severe adult onset OCD who felt better after surgery? I haven't seen any literature, but I have seen that occur. Let me just finish what you're saying, and then I'll explain. It is with severe onset of pure OCD, intrusive thoughts, and later when I ordered a PTH panel, my PTH came back as 89. That's the highest it's ever been. Could there possibly be a link between the two? I know hyperparathyroidism causes anxiety, and anxiety can make OCD worse, but on the other hand, many people with anxiety don't have OCD. I had kind of an eye-opening conversation with a friend of mine who's a psychiatrist, and he was explaining to me that anxiety has obviously a wide variety of presentations, and a very severe form of anxiety can manifest into OCD, right? And that, again, that's what he was saying, right? And based on what he's learned and seen. And so if you have a baseline of anxiety, or a potential for OCD naturally in and of itself, right? And you have hyperparathyroidism, obviously the hyperparathyroidism pushes the anxiety issue over and makes it worse. So it can push the OCD and amplify the OCD, right? Because, you know, what hyperparathyroidism does, it does two things that I think add to the experience of anxiety. One is obviously makes the anxiety worse. Two, it affects your memory. So if you have OCD and you're more anxious and your memory is not serving you well, then you start like, you know, doing things repetitively because sometimes you don't even remember that you've done that, you know? So it could very much feed into it and exacerbate it. And I highly recommend that you are having anxiety, OCD issues that are more extreme than what you've experienced in the past. And if you have hyperparathyroidism, treat the hyperparathyroidism because that's a non-medical, by that I mean not taking medications to treat the OCD. It's by removing an inciting factor. And that potentially can give you such an improvement that you may not be reliant on medications to function, right? And I always think that if you can avoid taking medications, you always have to give it a try. It's well worth doing, you know? I think our bodies as human beings was not designed for high concentrations of one chemical, right? One chemical, high concentrations is a way to kind of get around a problem as opposed to on a physiologic level address a problem. That's why older medicines, shamans used herbal medications because herbal medications have 400 or 500 phytochemicals all combining together to address a problem as opposed to one chemical that has really high concentrations. You know, and I think the pharmaceutical companies have gone down the path of one chemical treatment because that's a controlled way of seeing an effect. When you have 400 chemicals in one thing you give to a person, you don't know which one is doing what. But when you have one chemical in high concentrations and you give them to a person and they have an effect, you can say, okay, well, this chemical had this effect, right? It's a more controlled environment. But that's not how we evolved. We evolved to coexist with lots of a wide variety of chemicals that seasonally change based on the plants and fruits and vegetables that are around and available. In any case, I digress again. But I think, merely, best of luck. It's really hard, you know, and these are all anxiety-provoking times anyways, you know. I find all of us are feeling some experience of OCD at this point, washing our hands and trying to be clean and doing all these things. And so, you know, this is a terrible time for people who have anxiety and have hyperparathyroidism because it just really adds fuel to the fire. So I feel for you, I really do. And you know, and I know it's hard to get things addressed now, but the one thing, I don't know, again, I just gave you a whole overture about not taking medications, but then I'm about to tell you that maybe you should try Sensipar and see if that helps, at least during this time where you can't go address the hyperparathyroidism any other way. Potentially by bringing down the PTH and calcium, you may be able to, with the Sensipar, affect things. Just food for thought. I'm trying to not give you information that can confuse you, but I think you understand what I'm trying to say, hopefully. Best of luck, Marilee. Vonda Clark Nabe. Question 1. I was diagnosed with hyperparathyroidism, chronic idiopathic urticaria at the same time. I've come across a few articles about the urticaria possibly being triggered by the adenoma. Have you heard of urticaria being a rare symptom of primary hyperparathyroidism? Not urticaria directly, but I have seen a mast cell disorder. Now, allergy events are triggered by mast cells, right? So patients who have mast cell disorders, there are articles out there that show that parathyroid hormone is an inciting factor in causing the mast cells to overreact, right? So by extending that thought, it's very likely that if you have the potential for allergic reactions like urticaria, that your PTH could be a component contributing to it, right? I can't say that I see that as a very predominant feature. I have seen it in some patients. And you know, I have to say that I've been a neglectful doctor because I don't think I've followed up with those patients in order to ask them about their urticaria and I'll make a note of trying to remember to do that, because probably they are connected to some extent. Okay, question number 2. My mother, my aunt, and I have all been diagnosed with hyperparathyroidism. My aunt had an adenoma removed and has recovered. My mother and I are very symptomatic, so FHH does not seem to be the connection. Well, FHH, you just need to do a 24-hour urine 24-hour urine calcium and creatinine test, while at the same time doing a blood calcium and creatinine test and doing a calculation, and you can very easily figure this out. This can be part of the workup for hyperparathyroidism anyways. None of us have had any other endocrine issues except for hypothyroidism, so MEN does not seem to fit either. Great. Are there other genetic conditions that might apply? Well, you might have familial hyperparathyroidism without a syndrome meaning multiple different illnesses fit together, or multiple organ systems having issues fit together. But you may not have that. You may just have singular genetic based hyperparathyroidism, which does occur. And when it does occur, you can either have adenoma or hyperplasia. So you guys probably have hyperparathyroidism and should address it, both you and your mom. And hopefully that'll affect the urticaria. I have a suspicion that it may not be the source of the urticaria. It may be an inciting factor, and it may make it more manageable and less significant, right? So definitely address it, Vana. Larian Sorgman, Ben Kamal. My question is, I've been diagnosed with hyperplasia, had an ultrasound and CT scan with contrast showing no abnormality. They are recommending surgery. What are the chances of having surgery and finding nothing? My last blood work result, calcium of 10, PTH of 66, vitamin D of 45. About 10%. Let me explain. Let me flip this around and explain. The reason for it is this. So parathyroid glands develop in the throat, right? This is a long-winded answer to your question, but let me give it a try here. So when you're a fetus in your mother's belly, in the first few weeks of life, at about the 6 weeks of life, right? Right about the time people figure out that they are pregnant, is when the parathyroids are forming. So in the throat of the fetus, these invaginations occur, right? Right? And these pockets that are forming, the first pocket turns into your ear. This line here being the eardrum. The next pocket turns into the tonsil, this one. The third pocket turns into the inferior parathyroid and thymus, and these migrate down together, right? The parathyroid here, the thymus down here. The fourth pocket gives you the upper parathyroid. So this fourth pocket, the upper parathyroid travels a lesser distance. The lower parathyroid travels a much longer distance, right? So sometimes the thymus and parathyroid merge and go down here together. Sometimes the parathyroid goes even lower in the chest, right? So the ectopic parathyroid. Sometimes it doesn't migrate and stays up in the throat area, right? Sometimes the two parathyroids merge, fuse, and the person has 3 parathyroids. So 3% of people have 3 parathyroid glands. Sometimes, as it's coming, it leaves pieces behind, right, in its path, or overshoots, and a piece goes down here, and that person may have more than 4 parathyroids. So 3 to 20% of people have about 5 or more glands, right? So, in your particular case, Lauren, if you have, let's say, let me go back. If you have 4 parathyroids in the normal positions, and then you had a fifth one, which is all the way down here, a fifth one that migrated all the way down here, not visible, your surgeon may go in there and see these four and not find the fifth one. That is where I find problems sometimes, right? And there's a 10% chance of something like that happening, I would say, right? And that's where the expertise of your surgeon comes into view. Really, it's the expertise of your surgeon that when they go and see these four parathyroids that are in the normal place, does it to their eye and in their experience look like this potentially are four hyperplastic parathyroids that are all slightly larger, or do they all look normal and there's potentially a fifth one, in which case I'm gonna go look elsewhere and see if I see another one in the lower part of the neck. So the expertise of your surgeon would dictate that the surgeon would go, once finding these four and seeing that they're normal, does your surgeon go exploring lower in the neck and upper chest on both sides, and then up here to see if there's a fifth parathyroid, or behind the blood vessels in the neck, or behind the voice box and the swallowing tube. So that expertise is really important because, instead of giving up and quitting, do they go looking for something elsewhere, all right? And how comfortable they are, how adept they are at doing this. And that's when get an expert surgeon is important, okay? Best of luck, Lauren. I find that I'd say probably there's a 50% chance at this point that you do have hyperplasia. I won't say 100. Your surgeon may go in there and find that one of the parathyroid glands is clearly more rounded and more enlarged than the other ones, Normal parathyroid glands are 50% fat, roughly 50% fat, 50% cells. They're very squishy and flat and yellowish. Abnormal parathyroid glands get rounded, right? Instead of squishy and flat, they're rounded. They're a little bit more brownish in color. They have a little bit more blood vessels on their surface. That's the experience that a surgeon has done a lot of parathyroid surgery brings to the table, and I think that's important. Okay, Michael Melvin. Good luck, Lauren. Michael Melvin. Hello, Dr. Larian. Thanks, as always, for giving it. My pleasure, Michael. In your experience, do people tend to have a lot of muscle problems associated with this disease? I see muscle weakness as a common symptom, but I mean things like muscle pain in the neck and shoulder, that seems to never go away. I am pre-op. When the muscle aches are limited to the neck and shoulder, you're right, it doesn't often go away. But that's because we carry most of our tension in the muscles of our shoulder and neck anyways, right? Especially if we're having on the side of our dominant hand. So if you're right-handed and your shoulder and neck pain are on the right side, that tends to be more because you're just holding on tight. You're essentially holding stress in those areas. And then if you have hyperparathyroidism on top of it, then that compounds the problem, makes it better. But once you do the surgery, if you still have work stress, life stress that continues, then you may continue to have that. So generalized muscle pain and weakness is very much hyperparathyroidism, but very focal, like this area tends to be not parathyroid in origin, but made worse by parathyroid, okay? Hopefully that makes sense, Michael. And best of luck once you have your surgery. Karen Armstrong. Hello, Dr. Larian. Can you please tell us more about the study where patients who had hyperparathyroid disease took 450 milligrams of calcium and had lower calcium after 4 weeks? Thank you so much. I don't know exactly which study you're talking about, but let me explain the physiology. If you are having hyperparathyroidism secondary to low calcium intake, right? Which means that your calcium intake is too low for what your body wants, right? But if your calcium is too low for what your body wants, then your parathyroid glands produce PTH. Let me flip you around and again explain. So, all right, so this is the normal way parathyroid system works, right? So when your calcium is low, your parathyroid glands produce PTH. And when they produce PTH goes to your kidneys and tells the kidneys, absorb more calcium from the urine and goes in your bloodstream. It tells your bones to release more calcium, right? And when your calcium is high enough, you have a negative impact on the parathyroids, right? So when your calcium is low, you produce PTH, which goes to your bones and tells your bones to release calcium, tells your kidneys to absorb calcium, activates vitamin D so you get more calcium from your food, and all that goes into your bloodstream, right? Now, let's say your body wants a calcium of 9.8, right? Let's say, yeah, calcium of 9.5, right? That's what your body wants. And your calcium now is lower, right? And so your calcium goes to 9.1 or so, and your body keeps producing PTH, right? And by producing PTH, you go through these processes to bring your calcium up. If at the same time, your vitamin D is also a little deficient, right? Which means that your body, this vitamin D is absent. And because your vitamin D is absent, you don't have suppression of the parathyroids because vitamin D suppresses the parathyroid glands, right? So if vitamin D is low and you're not suppressing parathyroids and your calcium is low, right? And you're producing this PTH, then what can happen is that your body can overshoot and your calcium can go higher, right? And go to 9.8, right? And so the system is just overworking, right? Because it doesn't have the suppression from the vitamin D. Your parathyroid glands are not being suppressed, so therefore producing extra PTH, and you're going off, right? And if you take calcium under those circumstances, then you can normalize the system, right? Now the way to figure this out is by doing a 24-hour urine calcium, right? If you do a 24-hour urine calcium in a patient who has slight elevation in calcium levels or high normal calcium levels and an elevated PTH, if you do a 24-hour urine calcium and your 24-hour calcium is low, right? That may mean all you need to do is to take calcium replacement to correct it. So what I'm trying to say is that it's possible that if you have a certain population of patients that fit into this category and you give them calcium, and that's the right thing to do. They have secondary hyperparathyroidism due to a low calcium and probably vitamin D state, then they can, by correcting the calcium, they can actually normalize, right? But Karen, do me a favor and send me that study. I'll read it and see if there's more information that I can gather from that. I'll try to look for it as well. But I think that's probably the reason. If I were to try to figure out the physiology, how this happens, that's probably the way it works out, okay? Hopefully that makes sense, Karen. But if you send me the study or a link to it, and I'll try to look for it as well, I'll see if I can figure that out for you. Heather James. Hi, Heather. Hi. Hello, Dr. Larian. Can you explain how calcium affects the nervous system post-surgery? I've had mild neuropathy and on and off since surgery, and I'm so stunned that I have this. Let's go back here. I can't give you a detailed example, reasoning for what happens post-op, right? But let me explain to you how calcium functions with nerves. So this is a nerve, that has the fiber called an axon that comes and attaches, in this case, to a muscle, in this case, to another nerve. At that connection point here, right, if you were to magnify this, you would see the endpoint of nerve 1 that's sending the signal. This is nerve 1, right? And when the signal comes down, you see it in red here. When the signal is coming down and gets to the end, it causes opening of calcium channels marked in green. And when calcium channels open up, calcium goes into the cell. The amount of calcium goes in dictates how much neurotransmitter is released that goes to the next cell and sends the signal up, passes the signal on. So if you want a signal magnitude 90, the amount of calcium that comes in determines that magnitude. And then you have an equivalent of magnitude 90 neurotransmitter, dopamine, serotonin, whatever, going down to the next nerve, and then the signal goes from here downward just like it did there, right? So for the signal to occur appropriately, if your body thinks that your calcium is 9.0 and wants a signal magnitude 90, it opens up 10 calcium channels, 90 calcium elements come in, an equivalent of 90 magnitude serotonin, let's say, passes on to the next nerve, right? And that next nerve functions in that manner, passes the signal 90, right? But if, by mistake, your calcium is now 11, you open up 10 calcium channels, the magnitude of calcium signal inside is now 110, the signal that goes through is 110, right? And then the signal that's passed to the next nerve after this, or the muscle after this, is 110 instead of 90, which is what you intended, right? So when you have hyperparathyroidism for a long time, because hyperparathyroidism is a slow disease process, right? Your body learns to adjust, because you don't get hyperparathyroidism one day and the next day your calcium goes from 9.0 to 11. It takes a long time. It probably takes a year or two before this happens, right? And so this process happening in this fashion allows your body to adapt to it. And what I feel like is happening to people who have nerve issues that manifest after surgery is that sudden correction of calcium back to the normal range leaves nerves that had adapted to the new norm in a kind of a state of challenge, where they now have to adjust back to that normal number. The whole body has to adjust. And that period of time, I feel like patients will have nerves that are not functioning well again. And all nerves, not all nerves readjust at the same pace. So if there's misalignment with these nerves trying to adjust, then you're going to have symptoms that come up. And I think that, Heather, that's the reason people experience the nerve pains. And sometimes I've had patients that it's taken up to 2 years for those nerve issues to go away. And yes, your question is, have you had patients with neuropathy in the past while they heal? Yes, predominantly they have it in their feet, but I do have had it in all other places as well. So hopefully, Heather, that explanation helps clarify it for you. Neza Zain Lurta. Stay safe and healthy, Dr. Larian and family. Oh, thank you, Neza. I appreciate that. Likewise, all of you, please. Okay, Dylan Pace Rodriguez. Hello, Dr. Larian. Dylan from New York City here. Oof, at the epicenter. Dylan, stay safe, really. I recently went to the doctor regarding a thyroid nodule in my right lobe. The biopsy report came back as a follicular neoplasm. I'm wondering if this can cause parathyroid issues, as my calcium is always consistently high at 10.5 and high vitamin D, 125. Oh, at 91, okay, the 125 vitamin D, the active form at 91, which is on the upper side, and my PTH was 14 though. Can the nodule potentially be pushing on the parathyroid? No, the nodule is not the cause of your problem. The nodule is an independent issue. But the fact that your PTH is low is alarming. And I think it requires a more thorough investigation. So you need to have a workup of hypercalcemia. Let me flip you around and explain. So, hypercalcemia. Okay, causes of hypercalcemia. So, these are the causes of hypercalcemia. Hyperparathyroidism is one of them, the most common. Hyperthyroidism, adrenal issues, pheochromocytoma. Cancers can cause high calcium levels. Vitamin D toxicity. So this is for people who take too much vitamin D supplements. If that's the case for you, you need to do less. Sarcoidosis, which is an inflammatory disease, can cause it. FHH, medications like thiazide, diuretics for blood pressure, and lithium can do it if the person takes too much Tums, basically. Kidney disease, tamoxifen, but that obviously applies to people who've had breast cancer and are treating for that. Mostly women, of course, but sometimes men can have breast cancers too. Renal, kidney disease, people who are in bed, and people who are getting food intravenously, which obviously doesn't apply to you. But you need to have a workup of all the other causes, right? So you need a thorough workup to see, because when your calcium is high, your PTH should be low, and that's what's happening to you. So you need to figure out why your calcium is high. What's causing your vitamin D to be activated? There's a hormone produced by some other tumors called PTH-related peptide, PTHRP, and you need to look at that. You need to look at that as a potential cause. Sarcoidosis could do it, which creates a vitamin D-like protein. It usually doesn't cause an elevation in the 125, but my concern is that you need to have a full workup. So talk to your doctor, ask him to do a full workup for hypercalcemia, which should include a PTH-related peptide and ACE level. And if you go on my website, there's a handout, and I have a copy of it here. Let me flip you around, sorry. So this handout is on there, which not only rates your calcium and stuff like that, but also recommends some of the blood tests to be done. And here you go. These are some of the blood tests that you need, and PTH-RP and ACE level are one of them, right? So if you go to the parathyroidmd.com website, you can download this for yourself and use it and kind of guide yourself through this thing to figure it out, okay, my friend? But please go ahead and do that. Talk to your doctor and get that done, okay? It's just blood tests blood and urine tests, so your doctor doesn't even need to see you. They can order it for you. You can go to the lab directly and get these things done to get an answer. So you don't even require an office visit, right? So that's what I would suggest, Dylan. Good luck, my friend. Shannon Taylor, Dr. Larian, awaiting PTH surgery, parathyroid surgery, and I'm very symptomatic of arrhythmia. Unfortunately, now with COVID-19, I will have to wait until an unknown length of time. My symptoms are muscle, joint pain, fatigue, arrhythmia, and decreased kidney function. I have elevated calcium and PTH. I'm wondering if there's anything that might help. Absolutely, my dear. Talk to your doctor, right? Sorry, I got a phone call. Sensipar at this point. Yeah, Ave Maria Pospiek, Cher, also says I have the same things. So Ave and Shannon, both of you, under the circumstances where you cannot access your healthcare adequately, considering using Sensipar is a very good idea, because that can bring down your calcium and PTH, and by doing so can correct some of the symptoms you're having. And if you find that most of these symptoms go away, then at least you can use it until the time is right for you to have surgery done, okay? Best of luck there, but that's a very good option. I would encourage you to exercise. Paula Christine Metcalf. Hello, Dr. Larian from Cambridge, UK. Hi, Paula. Hope you guys are well. Daily chest pain, left lung and heart, shortness of breath even at total rest, and heavy crushing feeling top of the lungs, throat. My voice is crackier and I can no longer sing or shout. Most likely, Paula, this is due to acid reflux. Patients who have elevated calcium and hyperparathyroidism that can cause not only extra acid production, but also because of muscle weakness, the valve above your stomach the valve that's normally tight and closed and opens up when you eat and then closes again, that valve can loosen up and then acid can leak up through there and go up into your throat. And the symptoms that people get with acid reflux is a heaviness on their chest, feeling of pain and burning that can be in the front or the back, feeling of fullness, potentially like feeling a lump in their throat, hoarseness, feeling that you need to clear your throat a lot. Those things go along with that acid reflux, and it's very possible that it could be that. I'm 47. History of ruptured silicone breast implant 7 years ago. Silicone now in my left armpit. Oh, I've heard that escaped silicone in the body can cause high calcium. Would this also explain my high PTH though? No, it wouldn't. If you have high calcium from other reasons, right, and your calcium is high, your PTH would actually be low. So if you have a high PTH along with high calcium, then you probably have hyperparathyroidism. Levels of calcium and PTH not huge, but consistently above upper and lower limits. Vitamin D levels relatively normal. I do notice more typical hyperparathyroid symptoms, mood swings, aches, pains, exhaustion, brain fog, but find them much less distressing than the breathing and the chest pain. Everybody manifests differently. There's no guidebook on this disease and how it affects you. So, any of the symptoms can be disproportionately presented in any person. Weakness and fatigue is the most common symptom that everybody has. Would be eternal good for you to address this question? Absolutely. I've had next to zero help from any. Listen, I know London is going through a big COVID issue right now, and you'll have a hard time. What I would suggest is getting medications, over-the-counter medications. Because you're having it in such a severe form. So I would say medications as well as dietary changes. So let me explain the medications I would suggest, right? It's called omeprazole. I would take omeprazole half an hour before breakfast, and you need 20 milligrams of it, right? And then at bedtime, I would suggest taking another form of medication called famotidine, right? These are the generic names of the medications, so the brand names will be different in England, of course. And famotidine is 40 milligrams, and that has to be at bedtime, right? I would take those two things for now. I would also do dietary changes. By that I mean avoid spicy food. Tomatoes make you produce acid. Caffeine, coffee and tea can make you produce extra acid. Alcohol does as well. Citruses, oranges and lemons and things like that produce it. Apple cider vinegar, half a teaspoon every morning, decreases acid production. So I would do that. I would drink a lot of water all day, sipping water all day. That will help. So do those things to try to help yourself under these circumstances. It will take a while. It'll take a while to improve, so don't lose faith. It may take a month and a half or so before you find improvements, so stick with it. And under the current regime, I probably think you guys are going to be in lockdown for probably about that length of time anyways, so you can try to address this, Paula. Best of luck, and then I'll obviously treat the hyperparathyroidism. All right, moving on. I have 3 more questions. Doris Melgar, thank you for continuing to help the parathyroid community. My pleasure, Doris. I'm still looking for whatever else is going on. I continue to look for biochemical evidence confirming cyclical Cushing's with multiple elevated AM cortisol and ACTH levels, elevated chromogranin A, elevated neuron-specific indolase, elevated midnight salivary cortisol, elevated midnight serum cortisol, non-suppression of 1 milligram, dex suppression, etc. Recently, I pushed my endocrine to reorder metanephrine and catecholamines due to previously elevated levels. The urine plasma mets and urine CATs were all elevated, but not 4 times the upper limit. Urine dopamine is almost 3 times. Okay, it's so hard to enact change within the medical community. That is true. I've also been pushing a redo of the 40 CT scan of the neck. You ordered for me 3 years ago. After they screwed up the scan, they read a suboptimal 40 CT scan as normal. The reason the rescan came up as normal, no one has ever followed up on that repeat CT that shows something on the right inferior. Can't get anyone to help me here in Chicago. Trying to figure out how this all relates to have a small right superior parathyroid adenoma removed in 2017. Many tell me I didn't have hyperparathyroidism back then. I know MEN needs to be kept in consideration. Can't get docs to talk to me seriously. Tired of fighting of all. Yeah, I know. My calcium levels are on their way up again. 2.5 years post-op, getting calcium levels over 10 again. What are your PTH levels, Doris? If you can tell me that. I currently have masses on my neck that they say are just lymph nodes and not to worry. My neck felt one under my arm, under my jaw. In February, that was definitely enlarged. Everything on hold for now. For your information, dotatate scan was negative in March. Chest CT ergo elevated revealed a 4mm ground glass, which I've been told is nothing. MRI shows right upper kidney, not in the adrenal, too small to characterize. Pushing them to rule out a pheochromocytoma, pushing for repeat 40 CT scan. We are the low guys on everyone's totem pole, and COVID-19 now being on everyone's mind. I'm not being without compassion in these difficult times, but we still remain ill during this. Yes, you do. How do we get our needs met during this pandemic? Oh, it'll be really hard, dear. Really hard. Because everybody's trying to reserve resources for the pandemic and not other things. Having said that, imaging centers are open. I know locally our imaging centers are open and trying to treat patients that have needs that are more on an urgent basis. And I know for you, this is an urgent issue, but I don't know if it warrants you exposing yourself to potentially getting the virus by being in the healthcare setting in an environment where that's not going to take action. You know, if you do the 40 CT scan and they see something, they won't do surgery for you now, unfortunately. And so your needs are right now on the back burner, unfortunately. And I'm sorry to say that, but that's just how it is. I really want to help you promote the hyperparathyroid agenda, and whatever I can, there's something I can do to help you. Please let me. Thank you, Doris. Please stay safe. We will be the second wave of casualties after this strategy. Yes, a lot of diseases are taking that position, unfortunately. And I'm sorry you're going through this again. And it's going to be a little while before any doctor pays attention to anything like this. But hopefully they will. And I really thank you for your generosity in offering to help pass on the message. And I'm not sure what else to do. I mean, this platform is one thing I found, but I don't know what else is there. And then, so good luck, Doris. I appreciate your input. Ian McTavish. Hi, Dr. Larian. My surgery has been postponed due to COVID-19. The reason given was that after surgery I would be at greater risk for complications if I caught the virus, as my neck would be compromised at the operation site due to it being a respiratory illness and also the greater risk of contracting it in the hospital. Here in Australia, we are starting to flatten the curve, which I hope is not the calm before the storm. The winter flu season is now approaching here. Oh yes. At what point does the need for surgery outweigh the risk of disease? It's symptoms. It really is symptoms. If you're having kidney disease, kidney stones, or kidney issues that are heading you towards kidney failure, if you're having fractures by being at home and just doing minor things, by you having so much symptoms that it's incapacitating you, that's when I would say the risks outweigh. But this is a slow disease, so waiting a couple of months is not so deleterious. So I would think you should be okay. Breathing, and then last question. Ronald Curtis. Hello, Dr. Larian. What would you say is the likelihood that I have hyperparathyroidism based on the attached blood results? Calcium on the normal, upper side of normal, PTH on the upper side of normal, occasionally going in the high, vitamin D's, wow, wide range, but normal as of late, okay? When I look at your numbers, Ronald, when your calcium is lower, your PTH goes higher. When your calcium is higher, your PTH goes lower. So you have this reaction. So, and then you've normalized your vitamin D, and despite that, your last PTH level was 121, even though your calcium at that point was on the lower side of the numbers that you've had. I mean, it's hard to know based on what you have. What you're showing is if you have high normal calcium as your baseline normal, that's just how you are, right? In the normal range, the normal range for the US system is 8.8 to 10.2, right? So if your calcium is 10, constantly around 10, maybe that's just your normal, right? Okay, some people have that, some people have calciums that are at the 9, right? And a 10 would be elevated for them, right? So that's hard to know. And you're hovering in this high normal range and your PTH is doing this thing, right? And so it's reacting appropriately to your calcium changes. So it seems appropriate, but I can't be sure. Then do you follow this? A normal bone density scan, great. An ultrasound suggesting the presence of an adenoma. Feeling intermittently unwell for about a year, mainly with myalgia, poor sleep, and tiredness times. Well, if you have a target that's clearly an enlarged parathyroid and you're having symptoms, then I would say you are a candidate for surgery. And you can address, especially if you're young and you don't have any other medical issues, right? And young is obviously a different thing to everybody, but young, I mean, I don't know, I'm 50. I have to say that's very young, right? But I think, but when I say young, I mean young in physique and in the way you think. If you're an active human, if you're 75 years old, you're active, you're working out, you're exercising, you're seeing your friends, you're socializing, you don't have other medical issues, then you're young, okay? So if you're young and you're active and this is having an impact on your life and you know where your target is, then you can do a relatively simple surgery to address this, okay? So I think that's what I would suggest, that you have the opportunity to change the direction of your health in the future, and that's what I would do. And that's it, my friends. That's the end of the questions. It's really a pleasure to be able to help people on this platform, all the way from Copenhagen to Australia to here in America, New York City, all of you, Cambridge, everywhere. I mean, this is a wonderful way to be able to help people on a wider scale, I hope. And best of luck, everyone. Please take good care of yourselves and stay safe. Have a wonderful day.